feel very privileged to be able to present on this topic today. So we now have 4 CureJM Centers of Excellence, and I'm mainly going to talk about George Washington University, where I'm able to go twice in a month to see patients in consultation with the team at George Washington University. And Kaveh Ardalan will talk about Chicago at the Lurie Children's Hospital, and then Dr. Stingle and Dr. DeVerkston are going to speak about Duke Children's Hospital as another center. And there's one more in Seattle, and all the centers are posted on the CureJM website and the phone numbers as well to make appointments. So GW Myositis Center is a national referral center that provides a comprehensive and multidisciplinary consultation. We can help in establishing a diagnosis of juvenile myositis or provide an expert opinion on the clinical management. And it really is a collaboration between many people. It's a collaboration between GW that provides the support of their personnel and their space for seeing the patients in the clinic, with NIH that provides my time to come down there, with Walter Reed National Military Center, and Dr. Olje Jones is head of pediatric rheumatology there, and she's part of our team, and CureJM that has provided essential funding to help this center get established and continue. And it was really the vision of CureJM that really got the center started in the first place, because they really wanted a center where we could see patients that weren't eligible for NIH studies or that needed to be seen in follow-up after their NIH studies, and that could come for this consultation and even come back over time to be seen. So it was really their vision that really helped spur the whole center to develop. Another real aspect of this center, because it's located in the adult rheumatology division and hospital, is that we do really specialize in transitional care for teens, and we've had Dr. Patience White, who's been a lifetime expert in this area, involved with the patients at the center. And also that we're able to see and take care of young adults with juvenile myositis as well, with the partnership with Dr. Curiel as an adult rheumatologist. So GW is limited in that we can only see patients who are at least 7 years of age, and that we really can see people in consultation. So they would have a home primary rheumatologist or other specialists taking care of their child's JM, and we're really a partnering institution to really help that primary team at home. GW also performs center-based research in juvenile myositis, and one of the other real things is that there really is a lot of collaboration with NIH, and we'll talk more about that, and with other myositis centers. And it also is providing key teaching for a number of medical professionals and trainees as well. So the top reasons we find that families come to see us at GW are that the patients and their parents really want an in-depth expert evaluation, or even the home physician wants that. And we really have an advantage of being able to provide a team that can give the input. Again, we can help confirm diagnosis. We can help advise about treatment. We find people come when they're not responding to the standard treatments and need to think about new treatments. We find people come when they need to have help with certain illness complications, like persistent skin disease or calcinosis or lipodystrophy or lung disease or even other complications. And then this center is also able to think about access to new therapies. We have some clinical trials that have gone on, or even new therapeutic approaches that we're thinking about. It is the opportunity to give an outside set of eyes for review and a perspective to review the whole illness course and what have been the patterns with the illness, what have been the patterns of flare-up or patterns of lack of response, just to take a step back and try to revisit things and give a new perspective. Again, we talked about transitional issues in care, including the care of adult patients, and then that we are cross-fertilization between the institutions. So like we have some patients that first come to NIH and then they'll come and be seen later at GW, or they may come to GW first and then later qualify for a study at NIH. So we have cross-fertilization that way. Even with Dr. Olje Jones at the military, we have the military families coming for a second opinion consultation or an extra expert look at all those families as well. We have a team of people at GW. So on the left, in the middle, I would say, a second from left, is Dr. Rodolfo Curiel, who's the director of the center and our adult rheumatologist. Myself, we have Dr. Gulnara Mamarova, who's the second from the right, the woman with the black hair. She is a pediatrician and our scientist at the center. We have Dr. Oljay Jones, who's head of pediatric rheumatology at Walter Reed National Medical Center and also an immunologist. And then we have wonderful parent volunteers, and you're going to hear from them more directly. We have Michelle Best, the tall woman in the middle, who's not just a parent volunteer, but also now helps administrate the patients and schedule them, and you'll hear more from her about that process. Annie Mitchell in purple, and then Simonetta D'Onofrio, who's also a parent volunteer. Center was founded by Dr. James Katz, who was the former director of adult rheumatology at GW and the first center director for the first 5 years, and we're very grateful to his support in previously establishing the center. We have other specialists that we work with, Dr. Allison Ehrlich, who has been chief of dermatology at George Washington University and sees a number of our patients with active skin disease, Dr. Patience White, who's been a specialist in transitional care, and really had a focus of this throughout her whole career. And Dr. Kathleen Brindle, who's an expert radiologist in MRI. We have research collaborators, so Dr. Victoria Shanmugam, who is the head of the rheumatology division currently, and we're working with her and Dr. Derek Jones in her laboratory on the Batacept trial and research immunologic tests for that trial. Dr. Samuel Simmons in biostatistics, who's helped us with some complex analyses, and Dr. Josh Wistenholm and Keith Cole, who are initiating some new studies on fatigue and exercise. We see patients from all over the country. They've come from 33 different states to see us. They've also come internationally to see us from a number of different countries throughout the world. We also, an important part of our mission is training. So we have had 14 adult rheumatology fellows who have spent 1 to 2 days in a month for a 2-year period of time who have trained here. And I apologize that all the pictures aren't showing up, but all their names are listed. And the last 3 of our fellows that have rotated through the clinic actually have also been involved with the research portion, and they have even won local awards, or Dr. Erica McBride not only won a local DC Rheumatism Society award, but also at GCOM she was awarded a fellowship to come to the GCOM meeting in Berlin for the research that she was working on. We've had more than 50 medicine and pediatric and rehabilitation residents rotate through, and medical students from George Washington University and the Uniformed Services University. We've had 6 pediatric rheumatology fellows from the program between Children's National and NIH come through this clinic, and visiting faculty from even from other countries who have come to this clinic to learn more about juvenile myositis and all the assessment tools. This is maybe Michelle's entree to discuss about how to arrange your visit. So I'll just say a few words. I think I had a few more things to say, but I'll leave this part for Michelle about how to arrange the visit. A typical visit, and I apologize that the pictures aren't showing well. Typical visit, the team will get the medical records to review and will read the whole stack before you arrive. The fellow, the adult rheumatology fellow, and typically 1 or 2 other students or training doctors will go along with them to meet with you for 1 or 1.5 hours for an in-depth history and physical and general physical. And then they'll step out to meet with the attending physicians, and that's where the parent volunteers will come in to meet with you. And the attendings will review the key aspects. We'll hear the whole story, and then we'll review the key aspects, and then we will come in and do a detailed assessment more focused on the myositis part and develop treatment recommendations. We'll come back in to discuss those with you and your family and answer all your questions. While you're at GW, you may participate in a research study. Most of our patients participate in a medical record review study and sign consent for that. Some patients participate in some blood studies. We'll talk about that later. or they may go and see another consultant if their insurance allows. One of the wonderful things about GW, about this visit, is that there is no charge for the visit to come and see us. So no charge to your insurance. And then at the end of the visit, I will make a call to the referring physician, because we really are trying to partner with that doctor and improve your child's care. And we want them to understand what we think about what we saw and what we would recommend from here to try next, and try to give them some guidelines and even open the door for them to call back with questions in the future. And then you and your doctor will see a detailed report. It's a multi-page report. It's kind of nice because it kind of goes through the whole illness and what's gone on, and then the recent assessment and our recommendations. So here we go with Michelle for her part. I have some information back.
Okay, I just want to talk to you real briefly about the components and what we do in order to make sure that we get everything set and ready for your visit to the Myositis Center. So for a GW, as Dr. Ryder mentioned, we do need to collect all of your medical records. We typically request that you get them from the point of when you maybe notice the first symptom through the current state, so that we can get a full picture of it. We need those records no less than 2 weeks prior to your visit. Longer is better. It's really good for us to give our fellows the opportunity to have time with your records. Some of you will be sending records that are about this thick, and some of you will be sending a nice big old stack, and we need to respect their time. In order to get those records, that can sometimes be a little bit complicated. I'm willing to help you out. I'll do what I can. I'm going to send, when you come, you and I will be having a lot of communication about how to get yourself to GW. And I'll be sending you some forms that you can sign, and I'll help you with requesting the medical records if you'll sign a form giving me permission to request your child's medical records, or if you're a young adult, your own medical records. I'll be sending you some additional information as well. I'm going to be looking for a little bit of a history that you have for your child, to get to know your child a little bit better, the questions that you're going to be asking of the doctors, what it is that they're going to be looking at. So I'll be looking for that kind of information. We want to know that your physician is going to be willing to communicate with Dr. Ryder, so when she picks up the phone at the end of your visit, we need to make sure that your physician is going to answer the phone. So in that case, we'll probably be, in a perfect world, we'd like a cell number, but we definitely need a way to communicate with your physician. I'll send you information about charity flights. If you're eligible for a charity flight, there's a bunch of different options for you to check out. And then if you are coming, I am happy to submit a referral to the Ronald McDonald House. They do not guarantee that you'll be able to come, but we've never been turned down. So I always give you that little caveat that something crazy could happen, but we've never been turned down. And then just on a personal note, in terms of GW, I have a son who has kind of an atypical course with his adventure in juvenile myositis. And as a result, it has been incredibly important for us to get these second opinions, to have additional eyes to look at him. Please don't be shy. I had a physician at one point who wasn't too thrilled with our coming, but he worked with us. Please make sure that if you're concerned, you have questions, something just doesn't, you're not comfortable, you should be comfortable. You're fighting a big battle. Be comfortable. It is not telling on your physician, saying that they're not a great physician if they're asking for help, or if they're willing to seek help and to consult. It's really helpful for you to feel comfortable, for your kid to get the best care, if you're willing to work together. I can always be reached with all kinds of questions, so I'm really open. My email address is, you'll find it at some point. Dr. Ryder will show you how to connect to it. And then I'll give you my cell phone number, and I text, I do phone calls, I do whatever it takes in order to make sure that your visit is as easy as possible.
Thank you, Michelle. She's wonderful. Very easy to talk to and very helpful. My name is Simonetta D'Onofrio. My son, Marco, has JDM. He's 15. He was diagnosed about 6 years ago, almost 7 years ago now. And I'm a parent volunteer at GW. I live outside the DC metro area, so it's easy for me to get to GW. And one of the things that our clinic offers is the opportunity for families to meet with parents. It's not on a medical. We're not talking about medical topics necessarily. We're really just talking parent to parent, and sometimes that's very helpful. I've been told, you're the first person that I know outside of our family that deals with JM. That's not a doctor. And I think that can be very helpful. It's almost a relief sometimes to talk to someone else who has a child with JM. You're not alone. And we're always like shaking and nodding our heads profusely through each visit. First thing we do is we knock on the door and we ask, do you want to talk to us? It's not an obligation. It's just an opportunity. And we've never been turned down yet, but that's okay. If they want to turn us down, that's fine too, because we understand. I mean, I was there, so I get it. And like I said, it's not unusual for people to say, oh, you're the first person, first family, other family I've ever met. Usually I tell them a little bit about myself so that they know that I'm, was sitting in the same type of seat they were in. Right now, my son is doing well, but there was time that he wasn't. Sometimes I even show a picture of my son if the patient is of similar age, and just so they know, oh, there really is a person. And he looks normal. Yes, he does. And doing well. We start conversations. I ask a lot of questions, and they can answer if they want. To an extent, and ask any topics that they want to talk about. And sometimes, they know this is non-judgmental. This is, they can say anything, because really at that point, parent to parent, we understand. So I get questions from anything from, my kid only wants to eat junk food. What do you do with your kid? And does your child ever said this? What do you do if your child wants to do this? And we just tell them, Michelle is there, and myself and Annie, and we just give them our experiences. Theirs might be different, but it's a conversation that's helpful, we hope. Also, it's a time that we can give information and resources. I always refer them to curejm.org. And it's also a time that I can give them information about, hey, have you ever heard about your JM Foundation? And give them information, documents. You should go online. I give them my telephone number. I give them my email too, because sometimes even the website can be overwhelming. It's just so helpful. But I'm like, don't feel like you have to spend hours going through everything. Use it as a resource, especially at the beginning. And also telling them about things like our Cure JM Caregivers and Moms Facebook group, that if you have a question, you can ask another parent, because usually they don't know about that. And so they're happy to know there's other resources. Other things that we do is sometimes parents come in from out of town. They're there and they stay longer than just that 1 day or 2 days. So we give them information about, hey, what would your kid like to do if you were here for a longer stay? Where to go? And it's kind of a relief if they've never been to DC. It can be overwhelming. And then also tell them about things that are specific to JM. So, DC has the mall, an expansive land that you will walk forever and no shade. Where do you go? What can you see? What's going on that weekend in particular. So sometimes that can be helpful. Where to eat. And then most of all, and most importantly, there's a quote that a father said once, and it was probably the most meaningful time to me, and it explains why I do that. Why do I want to be a parent volunteer? There was a dad, and he said, I own my own business, and I always tell other people what to do. This is the first time in my life I can't believe there's something out of his control. And what more did he want to do than take this away from his kid? Do something for his kid. Control this so they wouldn't have this. What is their child's life going to be in the future? And then when I was telling him a little bit about my journey, Marco's journey, our family's journey, he's like, okay, so there's hope. I'm like, oh yes, there's hope. And that's why I do it, because I know there's hope. And that's something that just is conveyed genuinely. So anyway, it's a wonderful clinic and a great place, and privileged to be there.
Parts about the clinic are the parent volunteers and their time with the families. So it's really a treasured resource for us, and we're so grateful for all the time that they dedicate. Simonetta and Michelle and Annie Mitchell. And I know the families are extremely grateful as well. So I wanted to take a minute then to tell you a little bit about the research at GW. And really the research at GW is really based in different ways. We have some research studies that are only at GW. We have some that really are a combination of NIH and GW studies. And we have some studies that have been done at NIH, and we've collected lots of data, and it's through Dr. Mamarova and the fellows and students at GW that we're able to really get to analyze some of that data and have a look at it. So some recent things that we've done, we actually just have a paper just accepted, and there's a poster downstairs about long-term outcomes of juvenile myositis. It was actually a study prompted by this foundation where parents were asking, what do these kids look like when they grow up? So we pulled together our data from NIH and GW, and I will say it's a highly biased and referral population of kids that are still under care. But I think overall we were pleased that many of these people, their disease activity is fairly low and they're down on medications. And yes, they're facing some issues, but overall they're doing pretty well. We've done some large online questionnaire studies. So we had one on healthcare transitioning and people's readiness for that. We had one that Dr. Mamarova led on environmental exposures during disease flares, and could we identify any? And we did find some signals of some of the same things at illness onset, like sunburn and infection, were also factors that seem to relate to these disease flare-ups. Dr. Mamarova had a lot of experience during her time with me at the NIH, looking at our large registry, the Childhood Myositis Heterogeneity Study. So she has a lot of experience with this database, and she's been able to continue studies on it from GW Clinic, looking at patients with clinically amyopathic disease, looking at comparing how could we tell juvenile polymyositis from muscular dystrophy patients. So those are two studies she conducted from GW. GW has also participated in the large international genetics collaboration called Myogen. So they've been a contributor of patients with JDM for blood testing to isolate DNA for the different studies that have gone on, including the studies now that CureJM is supporting with Dr. Wedderburn's group and previously supported for the GWAS and immunochip studies. And then we have trials of new medications, and I'd like to talk a little bit about that. So I'll skip ahead and talk about that. So we had one very inspirational patient who came through the clinic who was very sick, really a lot of weakness, in a wheelchair, had a lot of deep skin ulcers and severe calcinosis. And in partnership with one of the local doctors, Dr. Arab Shahi, we saw this patient several times at the GW clinic and tried to get her the best treatment we could. And we tried on an experimental basis to use IV abatacept, topical sodium thiosulfate for her calcinosis, and later IV sodium thiosulfate. And this child had a marked response to these treatments. She improved her strength, her function, she healed these skin ulcers, and the calcinosis stopped progressing, and she was able to taper down on prednisone. I say this patient, this success story, inspired 3 different clinical trials. So from this patient, we then developed a trial to do Dr. Ehrlich led a small study to do laser administration of sodium thiosulfate for calcinosis. And then we had the sub-Q abatacept trial, and then now the NIH study that's looking at IV sodium thiosulfate for calcinosis. So it was from the laser treatment trial that Dr. Ehrlich led that we were able to learn about how could we better assess calcinosis. So this was a study that took very small lesions of calcinosis and then used laser treatment to apply the sodium thiosulfate a total of 6 or 7 treatments, 1 to 2 times monthly. And there would be a lesion that got treated and another one that wasn't treated, a control lesion. But we could see after looking at the lesion that had been treated with the sodium thiosulfate that there was improved skin pliability. The skin was less bound down and it had less scarring. And also that the skin assessment and we also looked at the pressure in the skin using an instrument called durometer, and that seemed to be less hard in the skin after the treatment with the laser treatment. We also had a calcinosis questionnaire that became the basis of another larger assessment tool that we went on to develop at the NIH for the other trial. So one patient in this study really clearly benefited from this laser treatment with the sodium thiosulfate, and one didn't have clear benefit. But I think one of the more important things was that new tools were developed to assess calcinosis. Then we have the abatacept clinical trial for juvenile dermatomyositis. This is open to patients who are having moderately active disease and not responding to prednisone and one other treatment, at least one other treatment, and they're at least 7 years of age. And the way the study works is that people can come and be screened. We try to work with the doctor at home and do a lot of the screening tests at home, so they only have to make one trip to GW. But once we find them to be eligible, then they come into the study. Everybody receives abatacept according to the dose that's already given for patients with juvenile arthritis. And they get that right from the beginning. They come back for a total of 5 visits over 6 months' time. In between, there are some phone follow-ups to be sure the patients are doing okay. At month 3, if they haven't responded to the treatment by then, that is that they have gotten worse or really not responding at all, then there's an opportunity to increase the dose if the family would like to do that. So then after month 6, if the patient has responded quite well, then we would be able to continue treating them at GW for another 6 months, or many patients would then be able to get the medication picked up by their insurance. And we are doing different studies within this study, not only by the core measures to look at response, but also things like MRI or these research immunology tests where those doctors that are looking at those measurements don't know anything about what treatment the patient is on and when, which sample it is during the visit. So they're able to take a look in a blinded way at how this treatment is working. So we're looking at the safety and tolerability. We're also looking at how well we could taper down on prednisone during the trial. We're looking at these different outcome measures, but we're also looking at how the patients are feeling. Some of the studies that Dr. Ardalan has been doing in Chicago, we're looking at like tiredness level, skin quality of life, general quality of life, how the skin activity is doing, and then the MRI and the blood tests. And so far, 7 patients have enrolled in this study, and our goal is to have 10 enroll. So we're looking for a few more patients. We have a number of other studies in progress, including, again, Dr. Mamarova is looking at the registry study, looking at patients with the MDA5 autoantibody, trying to understand more about their features. We have a study on muscle ultrasound and how that compares to MRI. That was data that we collected at NIH, but again, the analysis is progressing at GW. We have another study, it's a chart review type of study, but this is a combination of patients from NIH and GW, where we were looking for some treatment for patients with calcinosis and are looking at response to IVIG and pulse steroids for patients with calcinosis. And then we're planning some new studies with our physical therapist, Josh Wustenholm, and Keith Cole. One will be a questionnaire study that people can participate in from home, an online questionnaire looking at exercise and fatigue, exercise both in the beginning of illness, does it contribute to illness onset, but exercise later on, how are patients doing? Are they still having tiredness? Are they impaired with their exercise even after effective treatment? And then we're going to do an exercise bicycle test trying to look at whether we can see any correlates to the decreased capacity to exercise. So in summary then, GW is a national referral consultation center. It's for patients of at least 7 years of age, but we go all the way into the adult years. We're partnering with your home doctor at key points in the illness to provide insight to improve treatment for the patients at home. This is a partnership between not just GW, but NIH and Walter Reed as well. We're involved with treatment, we're involved with research, and we're involved with educating new doctors to learn more about juvenile myositis. We're particularly grateful to all the patients who have come to see us through the years, and we hope that we've been able to help them. So thank you very much, and we've been there for 11 years, and we particularly thank Cure JM for your continued support that makes this center possible.